more questions. So my first speaker, Dr. Faruk Orge, he's the medical director for Quality Eye Institute, University Hospital, and division chief of pediatric ophthalmology, Rainbow Babies and Children Hospital. He's widely recognized for his clinical expertise and is listed in the best doctors of America since 2009, an outstanding achievement. Besides being listed among the top doctors and who's who of America, his research interests comprise almost all aspects of pediatric ophthalmology, and he has received numerous grants, awards, and holds a patent for a novel glaucoma device. He has several other patents on drug delivery, eye imaging, wound healing, and other therapeutic technologies. So, wonderful to have you talking to us about utilization of UBM in clinical practice.
Thank you, Dr. Saxena, and I hope you can see my slides, and it's such an honor to be with you today. And again, thank you for allowing me to be a part of this fantastic organization. It's always a delight to be with the family. So namaste, and I'll go ahead and start with that. I'm going to talk about the utilization of the ultrasound biomicroscopy in clinical practice. I do have, as you mentioned, some relevant financial disclosure, but they're generally grants, and I do hold a patent on. We do hold a patent on some of the utilizations and acquisition that I'm going to discuss today. Before going into the UBM, maybe quickly mentioning the ocular ultrasonography is, as a reminder, may not be a bad idea, and as you know, widely used ultrasonography, and the companies are increasing. So the technology is not going away, and we continue to utilize this fantastic technology, and seems like it's evolving. A-scan, which stands for amplitude, is widely used for AC depth, the axial length, the IOL calculations, and the B-scan, the brightness mode, is fairly used. UBM is not a new technology. It's been around since 1990s, I would say. And beyond that, there's color Doppler imaging. So these modalities are maybe used a little bit more common in ophthalmology, but there are many other modes, as C modes, M mode, pulse inversions, harmonic, and contrast agents that are utilized in various different disciplines. And I think we need to start tapping into those too for different various reasons. The ultrasound, as we use in the human body imaging, ranges between the 2 and 100 and beyond megahertz. The lower the megahertz, the penetration is deeper. So for an abdominal ultrasound, you would actually use the 2 to 4 megahertz. The higher the megahertz, you have a lower penetration, but the resolution is higher. Hence, the ultrasound biomicroscopy is 40 megahertz and beyond. A scenario like this, none of you are unfamiliar with such a, so this is a patient with a trauma. It may be hyphema. In this case, there's fibrotic tissue in the AC. You have no idea what's going on in the back of the eye. So what do? The OCT would not help you. Direct visualization is impossible. CT scan, MRI will not be really giving you that detail. Then we refer to the ultrasound as we use it. And this is the B-scan mode, as you all know. B-scan is used for many things: retinal detachments, tumors in the eyes, looking for calcium, and sometimes strabismus surgeons like us do use it to visualize the insertion of the muscle. That was eloquently kind of put by Dr. Stephen Kraft many moons ago, and many others. But UBM, the ultrasound biomicroscopy, can allow better penetration through the iris and corneal opacities, as we mentioned, and especially to see the finer tissues like collector channels. Apparently, you do need even higher, like 80 megahertz or higher resolution or megahertz in that frequency. And what it looks like is, again, this is, I think, a fantastic invention, that you're seeing the clear scan that is put over the probe itself, and if it's anything, I have no financial disclosure in that, but it really allows you to utilize the probe in any direction, and so in an upright or supine position. I do, though, deflate this balloon or clear scan fairly much so, because if you have this tight configuration, the balloon tends to push on the tissues, and you will have changes in the iris as well as the other tissues. And then you get an image like this on the right side. And you can see the ciliary body, the processes, the iris, the cornea, the anterior chamber. So another example, this was a patient that was supposed to be an ROP examination. For the first time I'm seeing this patient, all of a sudden, well, the patient is looking like this now, but was opacified cornea. We didn't know what was going on. Well, UBM. As soon as we did it, it was a Peters anomaly. Now we know what the condition is and how we deal with this. What you do is you do scan the probe just like any other ultrasound back and forth to really understand what's going on. We do use the UBM in particular for every case that I do, intraocular surgeries or exam anesthesias if it's applicable. But one thing we typically do is for particularly tube shunts. Whatever tube shunt you do utilize in glaucoma, you can actually really see where the tube is, where it's exiting, and the entire traveling path for the tube itself. Even you can look around the plate and see the differences. For example, this is a case that actually had a tube that was exposed. You can see it. There is nothing magical about this portion. But as a habit, I did actually do a UBM. I said, well, I just want to see what else is going on. And this is not a common thing that we see in pediatrics. The conjunctiva notinans tends to be a little more thicker. And lo and behold, just underneath the tube, as you're seeing depicted in C1 and C1 there was a scar tissue building underneath the area, underneath the tube, and it was pushing the tube up. And if you didn't know that, probably you wouldn't understand exactly what the mechanism is, and just removing that really helped the pathology. It really helps us to really see, as in our case, I deal with pediatric population, and we see them obviously grow. You put a tube, that the tube and the mechanism and the hardware does not grow, but the patient does. And really good to see how we started, where we started, and how the tube is. It's not uncommon as the eye does grow that the tube tends to kind of regress, and that's what we were seeing here. It's kind of regressing back, but we do see some tube migration in different directions too. So you don't want it to be migrating towards the eye, and you wouldn't see this and you wouldn't know this until you did a UBM. It really kind of shows you this detail in good fashion. And also we've been using to understand if after a tube shunt, if the glaucoma or the IOP is increasing. And we need to understand what the mechanism is. Is the tube not functioning or other mechanism? One common thing that we do see is the bleb itself, the wall gets very thick. It really is a thick scar like a cardboard. And you can see how we're really cutting through this. And some of the scar tissue formation, so to speak, does grow into I use an Ahmed valve, and it goes into this Ahmed valve too. So it really kind of shows you, as you're seeing here, what kind of a bleb that we're dealing with. And in the top left corner, you can see this very thick scar, again, depicted with C1. And again, in the top right, you see this. In the lower one, the middle one in particular, you can see in the center, the Ahmed plate and a big, huge bleb around it with a relatively thinner wall of the bleb itself. You can see that these two patients act and could act very differently. For more adults, but we sometimes see this in pediatrics as well, but this was an adult patient. Since I utilize the UBM quite a bit, the adult colleagues that do send many patients for me to image. So this is one patient that actually had this IOL haptic that had been in the partially or one haptic was in the sulcus itself and was rubbing against the iris. And you know exactly what's going on and the details. This is such another case, another UBM. This is again a sulcus lens. In this case, again, the haptic itself was bent forward, rubbing against the iris again, and then you can actually decide what you're going to do for the case. It is actually fantastic in ultrasound in many masses, but particularly angle, which is very tough to get to, as you're seeing here in the top left and the top right. these are two different ways of scanning. You can actually really define. This was a patient, again, in VA, an adult patient. They did actually see serendipitously with a gonio examination, but the OCT didn't show any details. So we did a UBM. You can see exactly the internal reflectivity, the amount of, and the extent of this tumor, and the patient was taken care of accordingly. Now, one step beyond, and I'm going to talk about a little bit more about the three-dimensional UBM that we've been working in the last 5 years. And you can see many things like iris cyst in the sense that we are actually able to get three-dimensional images, and these are two different cysts. And the iris cyst comes in. I'm going to go back to the 3D UBM in a later slide, but just to show that the cysts, and the cyst can come in a very different configuration. So actually, this is not an iris cyst, but it was initially thought it was. And you're seeing this as kind of, it was an epithelial downgrowth from a trauma, a corneal laceration that the patient had. And it caused this amazingly big cyst that was distorting the entire thing. And the UBM really kind of gives you the picture. And through that, we were able to remove it. And actually, the patient did have one more surgery after this. And we did remove the lens as well, and doing well with 20/25 vision. Trauma. In trauma, really, we utilize the UBM very frequently. Obviously, you have to be careful and not to push on the eye, as we talked about, just like any other ultrasonography or any other modality. But this is the actually normal eye of the same patient. And here we go. There's this traumatic cataract, as you can see. I think it's very important to really see the extent of the trauma. Did it really affect the anterior? Where did it affect the anterior capsule? Did it affect the posterior capsule? Will allow you to plan the surgery accordingly, and what kind of lens that you're able to put in the eye. And again, I'm going to talk about a little bit more, but this is our attempt on the 3D ultrasonography, and I'll go a little bit more faster for the sake of time. And we can zoom in. You can, when we have this NFOS image, you can actually turn it in any way, and we really can see the details of the capsule and many other structures. And actually, we did end up, after removing the lens, put a single piece IOL in the bag, and because it allowed us to do it. And we could see that the capsule was intact, and sure it was. Back to the three-dimensional UBM that we are lucky to be able to use. We are getting 1,000 images, and it could be 500, it could be 750, but we, for some reason, chose 1,000 images. 1,000 images consecutively, one after another, through a devised model like this, and it could be really any kind of UBM. And then you put these 1,000 images together, and you stitch it together, and you just make this one composite image. This was our first cadaver eye that we had imaged, and that's, and you can see the details. And SumOfAll actually does show a little bit more than the pieces that you see individually. For example, this white ring that you're seeing is the scleral spur. You can see the details of, and I showed you the iris cyst. You can see the IOL inside the eye. You can even segment these particular other devices as the IOL, and really see the configurations around and the relationship of where, if there's a scar tissue around, if there's a where does the haptic live and lie in a very better format. And we've done many validation studies. We're doing iris segmentations. When you have a composite image like this, you can actually really look at the iris as a whole. And not only that, you can actually, we are able to look at the angle and calculate it. And if you have a 360-degree and composite image, then you have a heat map of the iris angle. And we've been working on that and comparing with manual measurements as well. So AI is kicking in very significantly. And these are our attempts on looking at the ciliary body and processes, especially for laser cycloablation patients to see the effect, and potentially, or to see different effects of different surgeries or the growth that is affecting on the eye. And we are starting to measure volumetric entities for various pathology as such. These are, again, some examples of our validation. We actually, just to kind of now, because we can do a volumetric measurement. So let's say I want to measure a volume of the tumor and to see if it's shrinking or is it growing with treatments or just with time. But we have to start from somewhere. We said, well, anterior chamber is an easier place to start. And the ground truth, as you're seeing on the left eye, is the manual. So we had actually 3-4 people individually, pixel by pixel, defining the ground truth. And then we kick it to the AI, the deep learning. And the deep learning, as you can see, the difference was only just 3 millimeter cube, which is fairly remarkable. The current technology that you're seeing so far has been utilizing the slow mechanical scanning. I think the ophthalmic ultrasonography is overdue to get to the next level, because it is available. There are new technologies available that is not utilized in ophthalmology yet, but it's going to be hopefully. And the new technology is actually can be 100 times more. There's no mechanical arm moving back and forth. It's just the beam is the ultrasound beam is sent in a very fast fashion. And one more thing to kind of see is it does actually allow not a focused area, which actually is defined by the settings of the ultrasound. The entire thing can be in focus. Then the next step could be maybe imaging the entire eye as is, and then applying that. And these are some of our attempts of applying the AI and deep learning. And the red one you're seeing on the left is the retinal detachment, and the right is a foreign body in the eye, and you can see these as well. And thank you, and again, one more time, thank you for allowing me to be a part of this session, and namaste.